Welcome to today's Explainer. We are going to dive deep into the world of corticosteroids today. And I mean, we're meticulously unpacking this point by point. We'll trace the whole journey from natural physiological secretion right down to the precise, non-negotiable rules of safe clinical tapering. No skip details here. The goal is to clear up these concepts so thoroughly that you can leave the textbook on the shelf. So, let's just get right into it.
Okay, here's our game plan for today. 1. The baseline HPA axis. 2. Replacement therapy rules. 3. Corticosteroid equivalencies. 4. HPA axis suppression. 5. Adrenal insufficiency symptoms. And finally, 6. Safe steroid withdrawal.
Starting with Section 1, the baseline HPA axis, or natural steroid production.
Right, so before we even think about introducing medications, we really need to understand what the body does on a normal day. Under just basal, everyday conditions, the zona fasciculata of your adrenal cortex naturally pumps out about 15 to 25 milligrams of cortisol daily. Oh, and a quick side note, hydrocortisone is literally just the pharmaceutical name for this exact same compound when we prescribe it. Along with that cortisol, your body's also producing about 1.5 to 4 milligrams of corticosterone every single day.
Now here's a number you absolutely got to memorize. 90 minutes. That is the approximate half-life of cortisol. It's incredibly short, right? And that's actually a crucial detail, because as we'll see a bit later, it totally dictates our clinical dosing strategies when we're trying to mimic the body's natural rhythm. Let's walk through the chain of command, which is a really elegant three-step cascade. Step 1, the hypothalamus releases CRH, or a corticotropin-releasing hormone. Step 2, that CRH knocks on the door of the pituitary gland, stimulating it to release ACTH. And then, Step 3, that ACTH travels down to the adrenal glands, telling them to release the cortisol we were just talking about. It's a perfect feedback loop where each step triggers the next to keep those baseline levels steady.
Moving on to Section 2, replacement therapy rules, when the axis fails.
So what happens when this beautiful natural system breaks down, and we actually have to step in with exogenous steroids? Well, we have to completely tailor our treatment based on exactly where the failure is happening. Say a patient has primary adrenocortical insufficiency. You probably know it as Addison's disease. In that case, the adrenal gland itself is failing. That means we have to replace both glucocorticoids and mineralocorticoids. But if they have secondary insufficiency, meaning the pituitary just isn't releasing enough ACTH, their mineralocorticosecretion is usually totally fine. So in that specific scenario, only the glucocorticoids need replacing. Precision really matters here.
For standard physiologic replacement, assuming there's no acute stress going on, you've got two main options. You can use hydrocortisone at 20 milligrams orally every morning and 10 milligrams every evening. Or you can go with prednisone, using 5 milligrams in the morning and 2.5 in the evening. Notice that split AM and PM dosing? We're deliberately giving a larger dose in the morning and a smaller one at night to mimic that natural biological rhythm of cortisol we looked at earlier.
All right, Section 3, corticosteroid equivalencies, comparing the interventions.
Since we have all these different types of synthetic steroids, we absolutely have to establish their equivalent strengths. If you're going to safely swap a patient from one steroid to another, you need to know the conversion math. Let's compare the equivalent daily doses. To get the same physiological punch, you'd need 25 milligrams of cortisone acetate or 20 milligrams of hydrocortisone. But watch what happens as we go down the list. You only need 5 milligrams of prednisone, just 4 milligrams of methylprednisone, and a microscopic 0.75 milligrams of dexamethasone. Seriously, underline that in your brain, the potency difference between 20 milligrams of hydrocortisone and 0.75 of dexamethasone is massive.
Let's shift our focus to the mineralocorticoid potency of these same drugs. Cortisone and hydrocortisone pack a strong 2+ potency. That's exactly why they're the go-to choices for chronic primary insufficiency, like Addison's, where we literally have to replace those mineralocorticoids. Prednisone just has a mild 1+ potency, and both methylprednisolone and dexamethasone have absolutely zero mineralocorticoid activity.
But that mineralocorticoid strength comes with a huge warning label. If you use cortisol or cortisone for chronic therapy in conditions other than Addison's, let's say for hypopituitarism, that high mineralocorticoid activity becomes incredibly dangerous. It basically tells the kidneys to hoard sodium and dump potassium. And what does that lead to? Unwanted salt and fluid retention, hypertension, and hypokalemia. Not good.
Okay, Section 4, hypothalamic pituitary adrenal axis suppression.
So This brings us to kind of the dark side of our interventions. When we pump in exogenous steroids chronically, the body senses all those high levels in the blood and essentially just goes to sleep. It shuts down our natural baseline production. Let's run through the exact thresholds for this. If someone's taking less than 40 milligrams of prednisone in the morning for under a week, suppression is pretty unlikely. Same goes for every other day therapy of under 40 milligrams for about 5 weeks. But here is where we hit the danger zone. Actual adrenal atrophy starts happening after just 3 to 4 days of high-dose steroids. If you're doing 40 to 60 milligrams of daily hydrocortisone for 2 weeks, axis suppression is almost guaranteed. And get this, after a month or more of use, that HPA axis can stay depressed for up to a full year.
Which leads us to a really crucial concept. Recovery of the adrenal cortex lags behind the pituitary. When the system finally tries to wake back up, the pituitary starts firing off ACTH, but those shriveled up adrenal glands take their sweet time responding. So, if you're measuring a morning plasma hydrocortisone, you're only evaluating the return of basal function. It absolutely does not mean those adrenal glands can mount a proper response if the patient suddenly faces severe acute stress.
Section 5. Adrenal insufficiency symptoms.
So, I've got to ask you, what actually happens when the exogenous steroids are completely gone, but the HPA axis wakes up way too slowly to provide the cortisol needed to survive? The clinical manifestations of hypocortisolism are no joke, and you have to know how to spot them instantly.
Let's look at part 1 of the symptom list. At first, they can be super vague. We're talking profound fatigue, muscle weakness, arthralgia, which is joint pain, anorexia, and nausea. And remember, a taper that's too fast won't just trigger these withdrawal symptoms, it can also cause a massive flare-up of the exact underlying inflammatory condition you were treating in the first place.
Part 2 of the list gets incredibly serious, moving straight into cardiovascular and metabolic collapse. You're going to see hypotension, orthostatic dizziness when the patient stands up, hypoglycemia, and dyspnea. If this isn't caught and corrected, it progresses to a full-blown Addisonian crisis, which literally carries a risk of death. We absolutely must prevent this.
And that brings us to Section 6, Safe Steroid Withdrawal, the off-ramp.
To prevent all that chaos, we need highly precise rules for tapering these medications so the body has time to wake up safely. First things first, map out the timeline based on how long the patient was actually on the steroids. If it was a short course, less than 5 to 7 days, abruptly stopping usually carries a very low risk. You can normally just stop. If they were treated for up to 2 weeks, you can safely withdraw them by tapering the dose over 1 to 2 weeks. But for any treatment longer than that, or if they start having withdrawal problems, you have to immediately shift to a strict conservative taper protocol.
Let's break down the first half of that conservative taper. Step 1. You make really small, calculated decrements. We're talking the equivalent of 2.5 to 5 milligrams of prednisone every 3 to 7 days. Step 2 is absolutely critical. You have to know when to backtrack. That means halting the taper, bumping the dose back up, and then resuming much more gradually. You backtrack in 3 very specific scenarios. If the underlying condition flares up, if steroid withdrawal symptoms appear, or if there's an intercurrent infection or a sudden need for surgery.
Okay, let's look at the final steps to get us across the finish line. Step 3. Once you've managed to taper down to physiologic doses, which is about 20 milligrams of hydrocortisone equivalent per day, you switch the patient entirely to 20 milligrams of hydrocortisone given just once every morning. Seriously, no long-acting prep here. Step 4. After 2 to 4 weeks on this morning dose, you check their AM cortisol level right before they take their pill. From there, you taper down by 2.5 milligrams weekly until you hit 10 milligrams a day. Finally, step 5. You just keep checking that morning cortisol every 2 to 4 weeks until the blood level hits greater than 10 micrograms per 100 milliliters. That's the magic number. It proves their baseline adrenal function is finally back online.
But I want to leave you with one final, kind of mind-blowing thought. Baseline function has returned, the daily steroids are gone. But did you know the risk of adrenal insufficiency can persist for up to 2 full years after cessation? Yeah, 2 years, especially during that first year. If the patient undergoes severe stress like a major surgery, you still have to give stress doses of steroids. Plus, you have to run monthly cosyntroprin stimulation tests until they normalize. Only then is the system truly repaired. Really leaves you with a profound respect for the long-term biological footprint these drugs leave behind, doesn't it? Thanks so much for joining me for this explainer, and keep exploring.